This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution or for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hi, I'm Dr. Sujana Chandrasekhar. I'm an otolaryngologist, which is an ear, nose, and throat surgeon with a specialty in ear surgery, and I practice in New York and New Jersey with ENT and Allergy Associates.
I'm Dr. Marina Kurian. I'm a general surgeon. I do a lot of laparoscopic or minimally invasive surgery, including some weight loss surgery and weight loss management here in New York City.
Welcome to our second show. Marina, I can't believe we had over 5,000 views for our first show last week.
That was fantastic. I think that has a lot to do with our team behind us and also our partnership with Scroll In, which is one of the leading news organizations in India. And it's watched internationally.
So thank you guys for tuning in. Please take a moment to like and share and subscribe. You can see us at She's on Call on Facebook, on Twitter, on YouTube, on LinkedIn. And please let your friends know. I hope you know somebody who might be interested in watching the show. Please ask them to come along and watch with us and send in any questions, any comments. We'd love to make this as interactive as possible.
Yep, when you send in questions, we're going to be able to answer them for you. Today we have a great show, but first, we want to say Happy Father's Day. And I know it's Father's Day, and you guys are all like, why are you having a show? But you know what? Everybody can learn any day of the week, and maybe this will be something fun and make you learn and laugh. So Happy Father's Day to my dad, Zachariah Kurian.
And happy Father's Day to my Appa, Dr. Hosekari Chandrasekhar, and to all those watching. And it's a somber day for people who have lost their fathers, particularly during COVID and during the uprisings here. And we send our love to all the families who are watching.
What we do on the show is our format is that we're going to talk a little bit about the news topics that have come out in the past week. And then we have two fantastic guests that are joining us every week. This week, Dr. Nadia Hernandez, she's an anesthesiologist down in Houston. Oh, Houston, right? Anyway, and then yep. Dr. Leland Lee, who is a ENT resident in DC.
So, Marina, maybe we'll start off by just explaining the name of our show. People ask me why She's on Call, and I love the name of our show, and I wonder if you want to share some of our thoughts about it.
So She's on Call. We came up with silly names, right? Like, well, not silly, but kind of boring, like women doctors talking. It just seems so like, too concrete, too not fun. And actually, one of our team, Rose Horowitz, she was talking about it with her family, and her husband actually said, why not call it She's on Call, which is kind of cool. And a lot of it is, when I talk to my patients and they're like, I'm going to see my PCP, I'm like, oh, okay, what's his name? So I can put it in my thing. And then I think to myself, wait, it could be, is it a she? So I make that same mistake. And I thought this was just a cool way to really bring out the fact that women are in medicine, and we are on call. We are answering questions for people every day, not just our patients, but families and neighbors and other people. Sujana, what were your thoughts about it?
Yeah, I agree. I think we are on call. You and I have been on call for a couple of decades now since we started our residency training. And it's one of the joys, really, of having some knowledge base where people in the street or at a rock concert or at a bar mitzvah can come to you. So I had a couple of funny incidents of being on call when I was all gussied up. So one of my best friends was getting married, and the ring bearer had a fishbone stuck in his tonsil. He just ate wrong. And he was a brave, brave little boy, and I could see it. Yeah, he had a fishbone stuck. this looks really attractive, deep in his throat, in his tonsil. And I looked in and I could see it just kind of sticking in the side of his throat. And really, I had to get to the reception, and so did he. And we went upstairs to the hotel room. His mother had a tweezer and we had a flashlight, and he was super brave. And I took out the fishbone and all was well. And we went back to the party, and he didn't, I instructed him, no fish, nothing with bones for the rest of the night because I wanted to have fun.
He probably doesn't want to eat fish ever.
Yeah.
So
Let me tell you, when a child is cooperative like that, it's a dream to be a doctor. You know, I had another incident. We were at a bar mitzvah, and they're all wearing suits. They're all 13. They're not used to it. It's hot in there. There's a lot of getting up and sitting down, and there's a whole bunch of God going on, right? And one of the friends of the bar mitzvah boy fainted. And, hadn't eaten properly. It was early in the morning. And so his parents and I went out and took care of him, and he was fine. And sometimes just being able to reassure people that they are fine, that, when you don't have to do something emergently. So She's on Call is a double or triple or quadruple entendre about the fact that we're on call for our patients, their families, but our families and our communities. And with this show, hopefully we'll be on call to the world at large and maybe share
big shoes to fill. But let's get
share. Yeah.
We want to talk a little bit about a couple of the articles that came out, and so we do have a slide, I believe, that we want to go over. This was a study that the recovery trial is like basically a huge study where they look at a bunch of different aspects of COVID-19. And this article just came out that talked about a low-cost use of a steroid, which is dexamethasone, that was shown to reduce death in up to 1/3 of hospitalized patients with severe COVID. So severe respiratory complications, and they also showed a benefit in patients who needed to have oxygen.
And so, people will ask many things, right? So does everyone who get COVID get cytokine storm? The answer is no. So COVID stands for coronavirus disease, and the 19 means that the first official case was identified on December 31st, 2019. So that's why it's called COVID-19. So really, even though it seems like we've been living this for a lifetime, we've only been living with this for 6 months and learning about it every day. And we know that 95% of people get self-limited disease and do not need to go to the hospital or get oxygen or get intubated. But a small and significant percentage get what's called a cytokine storm. So Marina, you want to talk about what a cytokine storm is?
I was like, cytokine storm, too much for everybody. But really what it means is that it's just a severe inflammatory response in your body. And that happens with certain diseases, and particularly in certain patients, you can get this severe inflammatory response with COVID-19. And when that occurs, patients are much sicker. So you can have someone have a severe response in the same family, and then everybody else in the family either doesn't get it or just has a mild form of the disease. And that is what's interesting right now, is trying to figure out why do some people get it worse than others. But what is important to note is that don't take steroids if you don't need it. If you don't have severe inflammatory response, if you happen to have COVID, taking a steroid won't prevent you from getting this virus. It won't prevent you necessarily from, having a severe response. What this study looked at was giving patients a low-dose steroid during their hospitalization, and that's where they saw the benefit, when they had severe disease or required oxygen therapy.
Yeah, and I think that's a really crucial point. Another recovery study showed that there was no clinical benefit from using hydroxychloroquine in these very sick patients with COVID-19. So that study was actually stopped. So I think, you pointed out to me earlier this week when we were talking that we just keep learning more and more and more about this disease. So don't go out and buy steroids. Don't go out and buy chloroquine. But if you are very sick, the dexamethasone is likely to help you and the chloroquine is not. And then we learned about who gets sick, right? There was another study that we found kind of interesting.
Yeah, this one is about blood types. I tweeted about this. I was kind of, okay, it's very interesting. So this slide shows you what the blood type distribution is in the United States. So there's a lot of O, there's a fair amount of A. I think they're the two biggest. Then there's B, and then AB is the rarest. So what this particular study showed was that the people that had severe COVID disease, there seemed to be a greater number of type A blood types. And the people who had much less disease, it seemed to be the type O blood type was protective. However, don't stress about that, right? Like with type A, not, as we said already, 90 to 95% of patients who contract COVID are not going to get super sick. So don't worry. But it's just more stuff that we're learning that, us geeks, we're kind of like, hey, wow, that's kind of cool. What does that mean? What is the interpretation going to be? So it's something that we're learning. And I think that if there is a blood type specific thing, and it really comes down to like the genomic or the genetic detail, then we might be able to come up with future therapies. But that's going to take years to weeks. Not years, months to years, not something that we can say, hey, turnkey, let's do this tomorrow.
Right. I agree. We have viewers watching from all over the world. I saw people watching from Bengaluru, which used to be called Bangalore when I lived there. In India, we have people watching from Mexico. We have people watching from Florida. We have people watching from Canada. We have people watching from all over the country. Thank you so much. Please send in Jonathan Borstein. I'm going to be your best friend. I'm going to track you down in Union Square because you are just a loyal follower of news and facts, and I'm going to meet you one day. So please continue to like and share and follow. You can find us on Facebook, on Twitter, on YouTube, on LinkedIn, and please send in not just your congratulations, but thank you so much, Renee Edelman, but your questions, because we have two amazing physicians joining us today. So Marina, would you like to introduce them?
Yeah, so Dr. Nadia Hernandez, again, she's an anesthesiologist who's going to be joining us, and Dr. Lillian Lee, who is also an ENT resident down in DC. Welcome, you guys.
Thank you. Thank you for having us.
So Nadia is on call, so we managed to snag her. This is, talk about she's on call. This is her, Nadia. I don't know. We can have it. But that's what happened. But we're just excited to have you join us. And hopefully, I'm not going to say the Q word, which is the death knell for all call. We won't say it, but.
Yes. So thank you guys for coming aboard. We have so much to talk about. And first of all, where are you guys physically? How are you doing? How are you and your families managing through what we've been through the last few weeks or months? So Nadia?
So I live in Houston, Texas, and Texas is having it's a major wave right now of COVID. I personally am managing okay. I have a very strict decontamination process when I go home to my children. So the nanny knows that when I get home, she hides them. I have an outdoor shower, and I have clean scrubs on that I take off and treat as they are dirty and completely decontaminate, and then brush my teeth and, Listerine the whole. And then I come in and interact with my children. I know some of my colleagues are living away from their families at the time so that they don't, infect them if they happen to be pre-symptomatic. But we're managing okay. So far, it's working for us.
Your children are beautiful. And I have to tell everyone, I knew Nadia when she was an anesthesia resident up in Mount Sinai, and she was a crackerjack then, and your star has just zoomed. So I'm so glad you could make the time. How about you, Leland? How are you doing?
Yeah, so I'm currently in Washington, D.C., starting my 5th year residency. And DC's actually done a really good job flattening the curve. People are staying home, working from home, and our cases are pretty low in the hospital. But I agree with Nadia. I decontaminate. There's a whole process when I get home. And so far, my close ones have been safe, and hopefully they'll stay that way.
Yeah, I think everybody has their process, and it's hopefully interesting to people listening to know that we all, when we come home, have our like little routines that we have to do to make sure that everybody else stays safe once we go into the hospital. Obviously, New York City has done a fantastic job flattening the curve, and I think the governor just said the other day that our infection rate was like one of the lowest in the country. Nadia, why do you think what's happened in Texas? And when we were at our peak in New York, some of our hospitals the ICUs were overflowing. The operating rooms became ICUs. That happened certainly at one of my institutions that I go to, and then several in the city. And then also what we found, and you went to Mount Sinai, so Queens got hit super hard, the Bronx as well, and then Columbia up in Washington Heights area, that also got hit. And so they had to create, ICUs out of rooms. And it was that's when we saw our resources being overutilized. And that was when we were all sort of worried that what's going to happen if this gets worse. And so that when we flatten the curve, which, is everybody sick of saying flattening the curve? Because probably we are. But once we did that, I think it made a huge difference in terms of decreasing our utilization. So when you guys are on the uptick in Houston, or is it all over Texas? So many questions. Go ahead, Nadia.
It is. I think it's focused mostly on the big cities in Texas. I think part of the problem was the early reopening without having an understanding that we needed to do it safely. The mask situation in Texas is a big deal. The mayors of all the different big cities were advocating for enforcing mask use. However, the governor sort of countered them, saying that we're infringing on people's rights. And I want to say that was probably interpreted as it's not that important. So what we were seeing in Texas is people were, congregating, not wearing masks. And as a result, we are about to be in a situation where, New York was a couple of weeks ago, where we're overwhelmed. Many hospitals are at capacity. We're starting to become overwhelmed. And although we have the advantage of having space, we could probably create thousands of ICU beds. The issue is now who's going to staff those ICUs. We don't have thousands of nurses just laying around, not doing anything, and doctors and respiratory therapists, et cetera. So I don't know. We're about to be where New York was, I think.
It was really hard up here. Not only did we face a paucity of like the trained healthcare workers, nurses, doctors, respiratory therapists, as you said, but even patient transport, linen. One of the audiologists, the people who test hearing here, she was dragged in to do linen and laundry in the hospital because somebody had to fold the linens and wash the linens so that patients could have their bedding changed. One of the other audiologists was pulled in, and if you called the switchboard in the hospital, you're like, hey, Lisa, what are you doing answering the phone? Because we need people at every level, and that's what we saw here. And we really hoped that the rest of the country learned from that. And I think the injection of politics into healthcare made the science not heard as well as it should. Even my mom, who's a physician, she's like, oh, come on. All you guys are saying is, wear a mask, wash your hands, keep distance. Wear a mask, wash your hands, keep distance. But that's actually the best medicine right now. And we've done it up here in the Northeast, and we're seeing that flattening of the curve that we talked about, in March. And unfortunately, we're seeing that curve rise in many cities. What's going on in DC, Leland?
So in DC, like I mentioned briefly, things are, people are really abiding by the rules. The streets are fairly empty. People are wearing masks out and about. And I think our hospital did a great job acquiring protective personal equipment for the healthcare workers. Initially in the beginning, the masks were kind of put in separate areas so people wouldn't bring them home. And, we were all kind of dealing with using N95s during the day all the time. But now it's kind of just become part of the routine. We're getting our PPE when we need them. And then in terms of our ancillary staff, they were originally sent to do some other jobs. Like some of our techs were sent to do fever checks at the front of the hospital. But for now, I think our volume has gone back to normal and they're back to their original positions.
I think if you guys can you pull up that slide for us on the on which states are seeing an uptick, and that will also be instructive, I think, for everyone that these are the places that have the ones in pink are the ones that have a policy for wearing masks in public. And we certainly have that in New York City. And what's funny is yesterday, is it yesterday? Yeah, probably yesterday. I was out and I was thinking, and I said to a friend, I'm like, look, everyone's wearing masks. Isn't that wonderful? I think in New York City, we're like 90% wearing masks. And then literally, I turned my head and then there were like 4 people who walked by without masks. But I think if the majority are doing it, I think that is still leaps and bounds better. And in addition, there was some data this week, and you could take that slide down unless Suju, you have something to say about it. There was data this week that suggested that what we're seeing for influenza, and now we're coming out of flu season, right? Over the summer months, we see less flu. But still, when there, as I said, troves of research here, as they're looking back through the past 3 months, they're seeing that there was a decrease in actual incidence of flu. So wearing masks, washing hands, all important. Funny thing, and I don't know if you guys have noticed this, but since everybody's using the bathroom right by the front door when they walk in, I'm like out of soap, right? And I'm thinking, how come this never happened before? How time to get, and so I realized because everybody would walk in, not necessarily wash their hands or do it in their own bathroom or something like that. But first I was a little bit creeped out, and then I realized it was probably for a national reason. It's not because no one's washing their hands. So, but I'm out of soap. After the show, I got to go get some more.
Dr. Lister would be very proud of your family, right? Dr. Lister was the guy in England who said the way we can reduce surgical infection rates is by surgeons washing their hands between patients. And he was almost run out of town as being a charlatan, but he was right. If we just washed our hands in between patients, we didn't contaminate other patients. And I think that's the origin of Listerine, which Nadia apparently uses frequently. So congratulations, Nadia. Let's move on a little bit. We have seen this COVID pandemic grip our country, and then we saw the extremely harrowing, horrible murder of Mr. George Floyd. And we saw these uprisings in the street. And, as physicians, we'd spent months saying, stay away, social distance, wear masks. And we saw, for the most part, the protesters were peaceful and were wearing masks and were, in fact, outdoors where it's a little less dangerous. But we did see some action with what's called rubber bullets, with tear gas. And Leland, maybe you can explain your experience and what prompted you to write this really eloquent op-ed in the Washington Post shortly after the June 1st Lafayette Park occurrences.
Sure. So basically, I was on call that Monday night where the Lafayette Square shooting happened. And, just kind of as a background, it was a day where most of you guys saw President Trump on camera giving a speech about what was going on in light of the George Floyd incident. And, honestly, for me, I was in clinic till pretty late and I wanted to get home on time before the curfew. There was a curfew set by Mayor Bowser in DC for 7 p.m. And just around the time that I got home around 7, I was called by the emergency room and they said there was a patient who had been shot by a rubber bullet while in Lafayette Square. And they wanted me to come in to evaluate him. So I looked on the CT from my house, and it was already very surprising just from the CT scan that there was a penetrating wound through this man's chin all the way to his bone, to his jawbone about here. And, I'd never seen a rubber bullet before. seen regular gunshot wounds. But, rubber bullets aren't really used in public generally, unless it's, in these particular circumstances. So I looked it up on Wikipedia and found out that, they're not just rubber. They have fragments of plastic, they have fragments of metal, and the rubber is just kind of the coating around the bullet. And, when I went in, I wasn't really sure what to expect. So I saw the patient, really gaping wound in his chin. And I ended up having to debride kind of the metal fragments, the plastic fragments out of his chin. Thankfully, it didn't really penetrate the bone and it didn't cause a bony fracture. So everything I did was at bedside, and he was really tolerant of me doing all that. And I closed him, sutured him back up and sent him home. So that was kind of the circumstance of what happened.
And that's hard. You guys who are listening, you think, hey, she was able to do it at the bedside. It's not so bad. I was just thinking, Lillian, how your back must have been broken because you have to lean over somebody. And you're at an awkward angle. It's not even like you're in the operating room. You're doing this in the ER. And then when we talked earlier about how you fished a bone literally fished a fishbone out of a child's tonsil, and you really need someone to hold still. I mean, all of us who have been in the emergency room, and Nadia, probably in your training, you were called out to help sedate a young child who was screaming and carrying on because they were not allowing, any kind of suturing or any foreign body retrieval. So for you to do that and it requiring that at the bedside, but not, and it was fairly deep, you said, if it was going down, that's multiple layers of suturing. And then, come on, it's like in New York, it has to be cosmetic too. Like you're not other layer of make it look real pretty, so it all adds a lot of time and it takes up a lot of resources. So
it definitely does.
Bullets had metal in them or plastic. That really is it's a weapon.
It is. And again, like you said, it was done at bedside and he did get to go home, but it took hours, and the patient was scared of needles. So we really had to calm him down before. He was a great patient. Obviously, he was very cooperative, but it, was a lot more traumatic for him, I think, psychologically, having to undergo that than anything else. And I had actually offered possibly to go to the operating room, but, he had family at home and he didn't want to stay in the hospital with all the other COVID patients who were there. So there were a lot of social factors that, led us to pursue the bedside route. And again, like you were saying, bedside procedure sounds pretty straightforward, but it was a lengthy procedure and he obviously had to tolerate that. So,
and this is during COVID, right? This is during the time when you're taking extra precautions, almost just to say hello to people, right? We're all wearing double masks and a gown and gloves and eye protection. So put all of that and a headlight on and try to help somebody who is scared and very frightened and appropriately scared of the lady leaning over him taking fragments out of his face.
Yeah.
A lot of times we
have a stranger, nonetheless, right?
Yes.
Stranger. Now everybody's a masked stranger. You walk into the hospital, everyone's wearing a mask. It used to be you could establish a little rapport. Hey, I'm Dr. So-and-so. I'm here to try and help you, and then we're going to do this. I'm going to put a mask on. And now, no, you don't even, you see this much.
Yeah.
I've been meeting new patients in the office and they're looking at me because, obviously they've seen pictures of me on my website. They're just like, I don't know, obviously I don't look like my picture, right? It's so impersonal in a way. It's not like we're the Lone Ranger. And that was a different mask.
Right. We have people watching from all over. We've got people from Durham, North Carolina. We have people from California. We have people telling me the salad bowl up in Northern California is still, the cases are rising. So even though the state as a whole looks good, there are pockets everywhere that are still rising. Monarch Mech asks, is there a safer alternative? Is there a safer alternative to be hit with rubber bullets? Yeah, don't be hit with any bullet. I think that
it's not as I said last night, it's not like me taking a bullet and throwing something, right? Like my colleague, I threw a ball for a dog and she was like, give me that. I'm going to throw it better than you. I was like, okay, I was clearly not got an arm, whatever. But it's not like I'm throwing a little rubber bullet at you, but it's coming out as a missile. So of course it's going to be painful, and of course it can cause damage, and especially if it just catches you the wrong way, right? If it's just there's not a safer alternative, and I think that probably the issues are everyone's tempers were up, the passions were flaring, and also we had COVID, and so just I think all that war, all the anxiety that people are having. I mean, when we're doing telehealth and we're seeing patients, everyone's anxious. They're scared about the future. They want to get out, but then they're afraid. Then they're all out, and now they see this huge police presence. I understand why they felt they needed to do crowd control, but it unfortunately there's some serious issues with that. So, Lillian, thank you so much for posting that.
Yeah.
Now, what have you seen in terms of what you do in anesthesia? Like, just tell people what it is that you do, and because Sujana and I were saying, what we tell our patients, yeah, you got to go under. Or you say they need anesthesia. I'm like, you got to go under. And they're like, what's that mean?
Right. There are so many different ways to provide anesthesia. And I can break it down probably into the most basic form. So usually it requires a discussion with the surgeon about the patient's comorbidities and the procedure that they're going to do. And we come up with a plan as far as what is the best thing that we can do for that particular patient. So sometimes it's determined by the procedure, but also sometimes it's determined by the patient's medical status. If the surgeon needs the patient to not move at all and muscles to be paralyzed in order to access certain parts of the body, or maybe align bones, and they need the paralysis, then you're sort of stuck having general anesthesia, unless it's in a part of your arm that we can just sort of block. But so general anesthesia just means that you are completely unconscious, and that we are controlling your breathing, either with a mask or with a special mask that goes in the back of the throat, or with a breathing tube and connected to a ventilator. Then there's options to not have general anesthesia. So we can do procedures under nerve blocks. If the procedure is isolated to a certain portion of the body, we use an ultrasound to find the nerves that innervate that region, and we anesthetize them. It's kind of like when you go to the dentist and they give you a shot in the back of the jaw, and sort of your whole jaw goes numb. We can do the same thing for body parts. So if that's the case, then we usually stand there and provide just a little bit of sedation to help you sleep. And then the other option is what we call monitored anesthesia care, which is MAC, which really just means that we're standing there, and we may just be giving oxygen, or we may be giving a little bit of medicine, but sort of helping the patient get through the painful procedures with just a little bit of sedation. Sometimes this is done without an anesthesiologist if it's a healthy patient. But if they require a little bit more management, then an anesthesiologist gets involved. So those are the sort of the general options. Now, in addition to nerve blocks, if the procedure is focused on the bottom half of the body, we can inject medicine, the same medicine, numbing medicine, directly sort of into the CSF where the spinal cord and the nerves live, and block half of the body. It's called a spinal, which most women get for C-sections. That's also another option, but we sort of group that in with regional as well.
A couple of years ago, I did the ultimate old lady thing, and I just took a step and I wasn't paying attention, and I broke my fibula. So I broke the smaller of the two bones in my lower leg, and I had to have surgery on it, even though I tried to convince the orthopedic surgeon that I don't really need a fibula. He said, yeah, you need your fibula fixed. And I had a really cool ultrasound and regional nerve block, and the anesthesiologist saw that I was a super nerd and allowed me to watch while he did the ultrasound, and found the nerve, and I could feel it block. And I'm really impressed with the way the machinery has gotten smaller and the technology has gotten better. And I saw on your Twitter feed today that you had posted a way to do it safely during COVID with pictures. So maybe you can talk about that sort of ultrasound guided nerve blocks, which I think are really cool.
So I'm an anesthesiologist by training, but I happen to specialize in nerve blocks and acute pain management, which is right up my alley. So thank you for that question. So we do nerve blocks for anesthesia, but we also do them to control postoperative pain or pain associated with trauma. And so the picture that I posted was related to a patient who fell from standing and broke their hip. We go down to the emergency room and we do the nerve block so that they won't get high dose opioids for pain and end up in a very confused state. Now, the challenge is, especially in Texas, that everybody's testing positive for COVID as they come in. And how can we go into these rooms safely with our equipment and do these procedures? So what I posted was a pocket ultrasound that I have. We put it inside of a sterile sheath, which included the phone, which makes it easier for us to go into these rooms because we have on our full PPE, but now my equipment has on full PPE as well. And we're able to localize tissue planes, nerves, bones that lead us to inject numbing medicine exactly where we want to put it. And then when we're done with the procedure, instead of having to wipe down this large machine, we able to sort of just hand over the clean ultrasound and phone to the nurse. And
there you go.
Showing it. Yeah.
But it's really cool.
The things you learn during COVID are that your phone works under plastic. Why is it that it doesn't work when you need a special glove to touch it? But look, you have a glove on and it's working through plastic. So hello, thank you, Apple or Samsung, for making these upgrades.
COVID. So I want to say one of our guests from last week's premiere show, Hafia Eltahar, just said hi, and thank you, Hafia. She's a resident at New Jersey Medical School, and she was fantastic last week, along with Dr. Dara Cass from Emergency Medicine. So we're so happy to grow our family like this. We've had people texting in and sending messages, and my daughter, who's 15, says the best alternative to rubber bullets is to not shoot people. And I think the safer alternative is not shooting at protesters. She's a logical girl. I guess she got it from her dad. Happy Father's Day to her dad. I'm wondering, Leland, your specialty is ENT, like mine, but unlike me, who went to the E, you're going down to the T. You're going down to the throat. And I know.
Yes, well, we all have our choices.
And then instead of doing all people, you want to do pediatrics.
Yes.
So maybe you can talk to our listeners and our viewers about what pediatric ENT is, and maybe what parents should look for, especially since children and small children are spending a lot more time in homes that may not be ideally child-proofed once the baby is, over 2 years old.
Yes. So, yes, I'm very interested in pediatric otolaryngology, and I love working with kids. They have some of the diseases are similar and some of them are a little bit different. And I think one of the things that, we were talking about was that kids are staying home more now, not going to school as much, and, they're, with their family at home more, but not necessarily with as much supervision. And one of the things that happens that we see a lot of is foreign body ingestion. And sometimes they have really acute onset. And so parents come in with their kids choking or coughing a lot, and they had an inciting incident. So the parents saw, that the kid had been playing around and choked on a piece of a toy, or were playing around and swallowed a button battery. So those are pretty kind of straightforward cases. You bring them to the emergency room and the kid gets a workup and possibly would need to get the foreign body removed. And again, in those instances, if you see that happening and if your kid is having those significant symptoms of, again, choking, coughing, difficulty breathing, then obviously going straight into the emergency room for professional help. Then there are kind of more subtle signs where a child might have accidentally ingested something. Again, toys, coins, button batteries, nuts, popcorn kernels, things like that. And they weren't really seen. The parent might have been turned away, and it's unclear if they really swallowed something or choked on something. But and sometimes they may not present with kind of the choking or immediate respiratory distress. But, if a child is constantly coughing, chronically coughing with no real source, they're otherwise not sick or anything, if they're having pain with swallowing, if they're drooling more than usual, and if they have this constant irritation in the back of the throat or, the pain, you may want to consider getting it evaluated as well, because they could have a foreign body that's lodged in either, the esophagus or the food pipe or the airway, the windpipe. And it could just be sitting there for a while, and probably needs to get removed. So all those things,
right? Because a lot of times when we have kids, Lillian, you may not, but they're like drooling and complaining of throat pain. I'm thinking strep throat or it's a cold, like that, and I'm very unlikely to think it's a foreign body. But it's an excellent point. And those watch batteries are like the worst, right? And if you have them around, they're like, hey, is this like candy? It's like a dime, or smaller than a dime, and they can easily swallow it and get stuck.
Yeah, so the batteries are really scary. They're one of the things that really prompt urgent consultation, and definitely bring your kids to the emergency room if you saw them swallowing the battery. And I think one of the things that was interesting that I learned was that CHOP did a study a few years back, and if you see your kid ingesting a battery, then en route to the hospital, or even as you're calling and waiting for the ambulance or whatever to get there, having the child just take in some honey helps to neutralize the battery and prevents as much caustic injury as it can before going to get further workup. So I think that's something that parents can easily do. Usually people have honey at home, and, just to have that around and having the kid take that as they're getting medical help.
Everyone needs honey at home. I can't believe that. That is amazing.
Yeah. It's really interesting. Yeah.
It's always nice when the doctors learn something too. So thank you.
I thought it was very funny. Yeah, they've tried a lot of different agents, and they found that honey was, again, very easily accessible and really helps prevent the degree of caustic injury from these batteries.
Because, the battery acid can burn through mucosa. So not only is it horrible to swallow battery, but then if it stays there and it's not so long that it takes, it can really burn through and make holes in your esophagus, in your swallowing tube. So that's that. And CHOP, for people who don't know, is the Children's Hospital of Philadelphia, and is associated with the University of Pennsylvania. We use a lot of acronyms in medicine. Doctors are sitting around talking. Nobody knows what we're saying to each other, but it's really...
We're going to have an ophthalmologist on, because I don't understand anything that they're saying.
I don't even understand. They do something and nobody knows what
is a little abbreviation. So, and the other nice thing about honey, by the way, I mean, like if you guys plant, I'm not a gardener, but my girlfriends that are, they all plant things that are for pollinators, so that bees will come, because of course we're having a bee problem, right? And that's likely. So we need bees to make honey, and now honey is so amazing.
So I'll tell you, we have a few minutes left. We're getting greetings from all over the place. My friend Irene, who I went to high school with, is now living in Texas. We have a lot of Texans tuned in today, and a lot of places, people saying that their mask wearing is really quite poor in many parts of the country, unfortunately. But I think I'm learning a lot today. One of the things that our viewers may not know is that when a child swallows a foreign body or inhales a foreign body and it goes down their windpipe, that's actually when Nadia and Leland work together. And maybe, Nadia, you can talk about, you talked about talking with the surgeon and comorbidities, and I think communication is just so vital in all aspects. But in the airway, in the pediatric airway, maybe you can talk a little about what you'd be asking Leland and how you'd be setting things up and preparing for a safe retrieval of that foreign body. Oh, I lost Nadia.
I lost you guys too.
Okay, I can hear you.
We can hear you.
Oh, I'm getting a phone on call. That's the issue. Sorry. I'm on call. Maybe Leland can start.
Okay, we'll leave in Leland. Leland, what would you tell your anesthesiologist?
Sure. So agree completely that it's a very close relationship, especially in these foreign body cases, especially in smaller children whose airway diameters are really small. They can lose an airway really fast and lose their oxygen levels really fast. So, figuring out a way to do an accurate diagnostic laryngoscopy and bronchoscopy to try to figure out where the foreign body is while allowing the patient to receive oxygen from the anesthesia end. So there's kind of various things we can do. And I think Nadia can talk more about that when she's back online, but just kind of coordinating to make sure, when my instrument is in there, the anesthesiologists are aware that I'm manipulating the airway, and, I can pull out the bronchoscope or laryngoscope if they need to ventilate the child. And I'll let Nadia speak more to that.
This is just one of those cases where you're right. We do have to work in conjunction because it's sort of a combined management of the airway. And it depends on where we think this foreign body is stuck. If it's sort of in the proximal oropharynx, and they just need a little bit of putting in a breathing tube to keep them safe, maybe because they ate, I think can happen. If the patient just ate, giving them sedation is actually very dangerous because you lose your reflexes, and if anything comes back up, it can go into your lungs and cause some really bad problems. So it's a lot of factors to consider whether or not we're just going to do a little bit of sedation so they can go in and get something that's very superficial, or whether they need to be really deep and we need to protect their airway even further before that foreign body dislodges and goes deeper into the body. So there's lots of options here.
We want to talk about something else that's a little bit controversial. I think one of the things that we found being women physicians is that sometimes we're met with issues. So one thing that came up in Twitter recently, and our executive producer Sri Srinivasan, kind of blew up social media by announcing when he was looking for a new job, right? Because that's not usually the thing. And so this was a way of using social media to help yourself, but also it was a great way of allowing people to know that, this thing happened, but I'm moving forward, and this is this is a way to help. And it opened, I think, my eyes to how social media can be used in many different ways. So this week, there was a an oncologist from Stanford that on Twitter broke her story that she was moving from Stanford to Yale and the reasons behind doing it. So Sujana, you want to talk a little bit about Dr. Kunz?
Right. So Dr. Kunz had been at Stanford for 19 years, had done her internship, her residency, her postgraduate training, was on staff there, and wrote on Twitter that as she moved up, she faced such gender harassment because of her success that she could not abide it any longer. She was grateful to those who were supportive of her, her patients, her colleagues, but she couldn't abide it and she left. And she's going over to Yale now, starting July 1st, which for those of you who don't know, that's the beginning of our academic year in medicine. And when we looked into this, JAMA, the Journal of the American Medical Association, had a study on self-reported sexual harassment in academic medicine, and women reported 30% of women reported sexual harassment, whereas only 4% of male physicians did. So this is women physicians in academics versus male physicians. And of the women who reported the harassment, 40% said it was severe, 59% said it decreased their confidence, and 47% said that it caused negative career effects. And, it really pains me that in 2020, this is what we're talking about still. And I wonder, either Leland or Nadia, if you feel comfortable talking about either your experiences or experiences you've seen other people have, or ways, in fact, that you are trying to combat this where you are. And I know, Nadia, your institution has a beautiful diversity initiative going on?
Yeah, I think many women experience this, and a lot of us are very, we're sort of afraid to talk about it for fear of repercussion. So myself included. You can imagine somebody who looks like me, a young female, appears to be single because I don't share my personal life. I get a lot of inappropriate comments. One time, a surgeon, sorry, it was not surgeons, but a surgeon called into the operating room where I was working and asked my resident, if I was single and if I would go out with him while I was at work, which, I'm loud and I'm not afraid to share my opinion. So that didn't go very well. But these things happen. And it's unfortunate that we have to deal with this day and age. But luckily for us, we do have each other to support each other. And I have a lot of he for she's behind me, which help, bring me up and redirect me when I get distracted by this negativity. So I just stick with my group of supporters and drown out.
It can be sexual harassment, but as we also say, it's like a gender discrimination as well, where you're not allowed opportunities if you're female, or if you're underrepresented minority, or if for whatever reason someone just doesn't like you. They don't really need a reason. And this used to happen in the old days way more often, I believe. I know that that slide was actually from University of Michigan. They have an incredible initiative for hiring diverse, creating a diverse department and keeping that diversity on every level, at every committee level within the institution. I have good friends that are there, and they've done just a spectacular job. Lillian, do you think, I would say that for myself in my training, I can see where the guys and the girls were treated a little bit differently. Mm-hmm. And I think it also depended on the personality of the individual. And I don't know, I didn't feel that I was necessarily discriminated against at all. I was also more of a tomboy. So, I don't know if that made a difference or not. And I think nowadays in training, Lillian, if you could tell us how you feel.
Yeah, definitely. Yeah, so it's interesting because when I was an intern probably 4 years ago, I was part of an intern class that was all men. And that included, we were surgical interns, so it was general surgery, orthopedic surgery, urology, neurosurgery, and it was just myself and one other female intern, and she was a neurosurgery intern. So, we had an intern room where we did a lot of kind of chart checking and doing daily, like note writing, et cetera. And it just felt kind of like a boys' locker room. No one was explicitly sexist or anything. And I felt like for the most part, I was comfortable being there. But just in surgery generally, there's so many men at all levels that we tend to be the minority. And, depending on the personality, like you were saying, if you were more comfortable, like if you were a tomboy or something, you probably fit in better into that locker room culture. But obviously, I think the more diverse both the attending and resident classes can be, the more inclusive, the program can be.
Yeah, I will tell you, one day we'll dish and we'll talk about all the horrible experiences because they were horrible. And I was so sad to see this week because the horrible experiences that happened in the 80s and the 90s to people like me should not still be happening in 2020. I remember our little call room. The boys put up all these Playboy centerfolds. So one of the drug reps asked me what I'd like, and I said, I would like a copy of Playgirl. Back in those days, the Playgirl centerfolds actually wore underwear because we were apparently very modest, even when we were sexual. And I just put up the Playgirl centerfold, and immediately the Playboy centerfolds came down, because I was like, I can't ask you guys to not make this disgusting, so I'm going to make it more disgusting, and then everything came down. And I think you have to be a little bit tough to do that. AJ Nathan, who is a rising third-year medical student at Boston University, wrote, we need more women leadership, and women are now the majority in medical school. We're about 51% of medical students, and we need to see that better reflected at the top. And talk about he for she, I think that we have so many male advocates that makes it easier or less difficult for us to confront the male bullies that we encounter. I had one guy, I mean, my residency was, when wheels were square, and there were no women almost in the residency program. And one of the guys I had spent 2 or 3 months with him on vascular surgery, and he sat me down on the last day and he said, he was really disgusting. He would say dead baby jokes. He would say all gross jokes, but sometimes they were funny. So I'd come back the next day and I'd say, I told my dad that joke. That was kind of funny. And he'd look at me funny. And at the end of 3 months, he said to me, I've been trying to make you cry for 3 months. And I said, you should have wasted your time. You should have told me to cry on day 1. I would have cried. We'd have been done. I don't understand that statement, but sorry for you, because that's a big waste of your time. But I think that these biases, whether they happen because of gender, because of ethnicity, because of sexual orientation, our LGBTQ brothers and sisters are experiencing this. I hope that by having more diverse leadership as we go forward, we are able to avoid this very unnecessary part of training and part of life. And I do think, Nadia and Lulun, when you talk about your experiences, I think there are not only he for she, but there's a lot of women who support other women. There are a lot of women we can go to in our hospitals who will hear and see when guys might not hear or see. And I think, ensuring that we are not mistreated by our patients or by our colleagues is really important.
Yeah, I think that is true. We are sort of out of time, so we want to thank you, ladies, so much for joining us. And perhaps, we'll do another show on gender discrimination and or just discrimination in general in medicine, because we do need to change that. But thank you, Nadia Hernandez. Again, she's an associate professor at UT Houston. Thank you so much for joining us on call. Amazing. Thank you. And Lulun Lee, thank you so much also for joining us. Again, she is a 5th-year resident in ENT in DC, and she's going, you're at MedStar, right?
George Washington.
George Washington, and she's going to do a pediatric otolaryngology fellowship. So congratulations to you and good luck, and thank you so much for joining. To those of you guys watching, thank you so much. I have friends also, Nancy from Indiana, Hoosier, and Brad from North Carolina as well, and Debbie from upstate New York in Albany. Thank you so much, you guys, for watching and sharing and liking our page. We really appreciate it. Again, we want to give a shout out to Scroll In for sharing this with their viewership, which we really appreciate. It's wonderful. This is our team, our producers, our design director. I want to thank everybody that was involved. Sujal, you want to introduce the next show?
Sure. I want to say, please keep posting and liking and sharing. Thank you to our dads for believing in us all the time. It wasn't hard. It wasn't easy to raise opinionated girls like Marina and me. So thank you to both of our dads, and happy Father's Day. Next Sunday, we'll be live again at 11 o'clock Eastern time till 12. With more medical information and 2 new guests, Dr. Olga Garcia and Dr. Jordana Cohen. So please continue to like and subscribe and follow and invite your friends. And if anybody wants to see today's show or last week's show, they are archived on our She's on Call YouTube channel and hashtag She's on Call. So thank you guys so much for tuning in, for all your comments, for watching and appreciating from around the world, around the country. It was great to see your names pop up in the feed.
Yeah. Actually, it's also super fun for me to hang out with Sujana, even if it's online. So thank you, Sujana, because that was really fun. I want to definitely thank our team again, because you guys have been awesome. And thank you to the viewers, because, this is why we're here, because we feel that we are helping educate some people and hopefully making learning fun.
Thank you. Stay safe and stay healthy, and happy Father's Day to everybody.
Happy Father's Day.